You can start, sir.
Thank you. So good evening, everyone. I am Dr. Sanket Nevale, representing Medical Affairs at Emcure Pharmaceuticals. Today, yet again, we join for another workshop, the No Thrombosis Workshop series in acute ischemic stroke, where we discuss innovative, difficult, at the same time unique cases in which teaches us how to manage stroke, at the same time what is the newest thing and the latest happenings in the world of stroke. With this, I would like to initiate our introduction rounds. I take privilege to introduce our course director today, Dr. Jayanta Roy, sir. Sir is a certified neurosonologist accredited by the American Society of Neuroimaging 2005, recipient of the 2005 American Society of Neuroimaging William McKinney Award for the best manuscript based on the clinical research in neurosonology, executive committee member, Society of Neurosonology, India, and member of Educational Committee, Joint World Stroke Congress, Hyderabad. Over 35 publications in various reputed national and international journals, editor of the various neurology books, that's Clinician's Handbook in the Management of Stroke and A Clinician's Approach to Neurological Disorders, guest faculty at many prestigious national and international neurological meetings and conferences. Sir, we welcome you for the event. We have our first moderator, Dr. Narinder Kumar Rai. Sir is a senior consultant neurologist at Neurocity, Bhopal. He is an ex-additional professor and head neurology, AIMS, Bhopal, founder faculty at the Department of Neurology, AIMS, Bhopal, having credit to start DM teaching program in any government institute in the Madhya Pradesh, fellow of International Intervention Neurology, Zurich, Switzerland, University Gold Medal for Best Resident Doctor, BHU, Varanasi, 25 research papers published in index journals, 12 abstracts in index journals, 4 chapters in book, chief guide and co-guide of DM and MD students, principal investigator and co-investigator of various extramural funded research projects. Sir, we welcome you for the event. We have the second moderator today, Dr. Arun Gaur, sir. Sir is a director, Institute of Neurosciences, Gurugram, South Delhi. Sir is a senior neurologist and a primary focus on stroke. He developed neurology services at Max Hospital, Patparganj. He has worked at Savai Mansingh, Jaipur University Medical College and Hospital, and Institute of Human Behavior and Allied Sciences, New Delhi. He pioneered the role of thrombolysis in acute stroke in this part of the country. His interest is also in neurorehabilitation, occupational therapy, and stroke prevention. His passion for stroke has taken him to UMass, MA, USA, and he has tied up with them for stroke prevention, education, treatment, rehabilitation, and latest research. Sir, we welcome you for the event. Our first speaker would be Dr. Srivarthan, sir. Sir is an associate consultant, neurology, MGM Healthcare, Chennai. He has multiple academic achievements. To name a few, All India Rank 2 in NEET SS Neurology in 2018, National Finalist of Torrent Young Scholar Award, Neurology 2021. Multiple paper and poster presentations at national and international conferences, multiple publications in national and international index journals, contributor author for multiple books. Sir, we welcome you for the event. We have our second speaker would be Dr. Jasmine Parihar, ma'am. Ma'am is a consultant neurologist at Yatharth Super Speciality Hospital, Noida. She's an assistant professor, neurology at Lady Hardinge Medical College, New Delhi. 18 publications in national and international journals, and case and poster presentations in multiple conferences. Ma'am, we welcome you for the event. With this, I would like to hand over the session to our course director, Dr. Roy, sir, for this context setting. Over to you, sir.
Thank you, Dr. Sanket, and good evening to all. It's already late. I'm sorry about the technical glitch, but today I am actually working on behalf of Professor UK Mishra sir, who is the course director all along in this no thrombosis series of programs, and we have been following him. So it's a big task, I know that, but in his absence, I am here to do that. But without wasting much time, I think we should proceed with the first case. And I think Dr. Jasmine has got the first case, right?
Yes, sir, I can start.
Okay, Dr. Jasmine, please show your case.
Thank you for this opportunity, the organizers, and thank you, esteemed consultants, for being here to attend this and guide us. And I'll be presenting a case, but before I start, I must tell you that not every case has a happy ending. So let's see what I have to say here. So I'll be presenting a case where case of acute ischemic stroke. One. So I'll be presenting a case that we recently had at our center. And this patient is a 64-year-old male, known hypertensive and chronic smoker. He was referred from ESIC to our hospital with right side hemiparesis and aphasia. And time from the onset was around 2 hours 45 minutes. His blood pressure was 186/94 and pulse was regular. And his NIHS score at presentation was 40. So this was his NIHS, in which the major scoring was in the palsy, facial palsy, motor weakness of the right arm and right leg, and also dysarthria. So we got his NCCT head done. In NCCT head, though in this image it looks like it is a dense MCA sign, but there was no dense MCA sign. This is just, I think, the windowing that error has created. And aspect score was 8. We decided to thrombolize the patient after ruling out all the contraindications. We before that, we also sent the patient after CT. We ordered for thrombolysis. We arranged for the things, and we ordered the CT angio simultaneously to look if there is any large vessel occlusion. We did not find any large vessel occlusion. All the vessels were very clear, and there was no evidence of any thrombus. But the patient continued to have a falling NIHs. But while we were doing the CT angio, the patient developed a little contrast reaction with a mild erythema. He had excessive shivering and tachycardia, but thankfully there was no rise in blood pressure. This was easily controlled with 1 injection of Avil and hydrocortisone. So we thrombolized the patient with altiplase. Full dose altiplase we had given at 3 hours and 45 minutes total. And patient started having improvement after almost half an hour of infusion. And after we completed the process of thrombolysis, this is our patient. He is standing and NIHS has improved to 2. The residual deficit was only mild dysarthria and mild facial weakness. We all are happy, congratulating each other. This is this call we received at around 10 p.m. and I'm about to leave, and all instructions given. And as I'm about to leave, the relative comes and tells me he started having the symptoms again. So he started having bursting again, but this time the symptom progression was very, very rapid. He started having deterioration at 5 hours and 15 minutes with recurrence of right side hemiparesis, aphasia, rapidly falling GCS, and drowsiness. We planned for repeat CT to rule out any bleed, but there was no evidence of any bleed. And we also could not see any developing infarct. We suspected rethrombosis or re-occlusion of same side large vessels, either MCA or ICA, and we immediately planned the patient for DSA and mechanical thrombectomy. We informed the interventionist team, and by the time they were arriving, we planned that we will take the patient for MRI. So since the patient was getting unstable, we could only do diffusion weighted image. And as we can see here, the infarct has started setting in, though it has not yet involved the territory, but it has started setting in. We could not do the flare image because the patient was getting unstable. We shifted him to cath lab, we intubated, and we decided for mechanical thrombectomy. So the patient was consulted for, the relatives were consulted, but the mechanical thrombectomy was referred in view of the financial constraints. And the patient, we decided then to refer the patient to a center where he might have less financial burden. But we referred the patient to AIMS, but this was completely refused by the attendants, and they decided not to take the patient anywhere and wait and watch it. We planned for early decompression, though till the time we had all this, we did not had real signs of mass effect. But looking at the clinical deterioration, we were very sure that he will have a mass effect, and we planned for early decompression, which was also refused. And by the late night, we lost all the relatives and we were unable to contact them. So this is the CT next day. The patient developed ACA as well as MCA territory, large malignant infarct, and his GCL slipped from M6 to M5. And on day 3, the GCS further dipped to M2, and we lost the patient on day 2. So the concerns mainly in this case are development of rethrombosis after a successful thrombolysis, that is reocclusion of the vessel after successful thrombolysis. And other important concerns that we don't like to discuss in the conferences and in the meetings are the finances, the cost of thrombectomy. The cost of thrombectomy in a private setup costs around more than 4 lakhs. That is one. And the other decision is the decision making in absence of relatives, who takes the decision. So I'm sure we are not going to discuss the second and the third, but they always keeps concerning me. So I thought that I'll just bring this up. So let us review the literature on what literature says about reocclusion after thrombolysis. So I did not find too much of literature, especially in the recent times, to address this issue, but immediate reocclusion following successful thrombolysis has been reported. In this study, this pilot study, which was conducted on 13 patients, they found in all the 13 patients who had reocclusion, they found that the immediate reocclusion after successful thrombolysis is a common thing. And the rapid rethrombosis at the site where initial occlusion appears, that is the site where reocclusion also appears. And generally, it is the high-grade stenosis at the site of initial occlusion where rethrombosis occurred. But this was not the case in our case. Our patient actually did not have any stenosis or any site where we could locate the initial thrombus. And in these patients, they had given IV abciximab with the good results in these patients. I had initially, till that time, I did not know about this, and I did not try this in my patient. And also thinking of this large infarct giving any other anti-platelet or anticoagulation, I was a little concerned. And here is another study where they have studied almost 60 patients who developed the rethrombosis after initial thrombolysis. The study reports that though in the literature 13% of the patients develop reocclusion, this study reported a high reocclusion rate of 34% after initial recanalization, with a high mortality of 25% versus 3% in the patients who do not have rethrombosis. And they said that the patients who have reocclusion are the patients who have earlier and partial recanalization. So in our case, our patients have very good recanalization in early hours. And they have a high neurological deterioration and high in hospital mortality. But the reocclusion outcomes, but if these patients undergo recanalization by mechanical thrombectomy, they are likely to have good long-term outcomes. But unfortunately, our patient did not get that. So we have seen that there are high reocclusion rates after thrombolysis, but this one article has also told us about that reocclusion rate is also common after mechanical thrombectomy, but the rates are only 2.3%, which is very less compared to the rates mentioned for thrombolysis. And in this study, in 12 patients who had a rethrombosis after reocclusion after successful thrombolysis, the patients were treated with balloon expandable stents, and they in this study 12 patients were included with a median NIHS score of 8.6 and time from symptom onset to intra-arterial. Like the patients initially had intra-arterial thrombolysis, which is a little different. We generally prefer intravenous thrombolysis. So these patients had intra-arterial thrombolysis, and the mean time from symptom onset to intra-arterial thrombolysis was 236 minutes, and median duration of intra-arterial thrombolysis was 62 minutes, and initial recanalization was achieved in all the patients, all the 12 patients who were recanalized after rethrombosis. And at the time of discharge, the NIHS score in 10 of these patients was 2.4. And in 2 of these patients, reocclusion of the stent also occurred. And they found that there was excellent outcome, 3 months outcome in 8 patients after they were stented for reocclusion. So this study concluded that this is an effective method to salvage the patient who have immediate reocclusion of the MCA after thrombolysis.
Thank you, Dr. Jasmine. I think this is one of those cases where everything goes wrong. Despite having a very good start, you can have a bad day, and this kind of outcome can happen. Well, before I start discussion, can you show us the CT-NG once again? Okay. So this CT-NGO, if you look at the CT-NGO very well, this left MCA was open at that time, right? And that was before you started thrombolysis, right? Or after?
No, so this is before I started thrombolysis. Like, I'm arranging for thrombolysis and simultaneously I'm going for CT-NGO. So maybe a little 5 minutes overlap can be there at max.
Okay, and so the most interesting part of this case is then if the terminal ICA and MCA is open before thrombolysis, then how he developed an IC occlusion later on?
Probably a cardioembolic origin.
Correct. So yes, because initially I was thinking about if there is any stenotic lesions in the terminal ICA supraclinoid part, but the CT-NGO looks so clean. So probably he thrown a clot in the MCA, a small one, because his NIH was not that big. Maybe a branch occlusion at that point of time, which opened up with TPA, and he had thrown another big clot, which has occluded his ICA, and he worsened. So I think this kind of cases, unless you go for mechanical, you do not have any option to open the artery. And rest of the things, I mean, family disappeared, and those are unfortunate things, but they do happen in private hospitals. So unfortunate. Dr. Garg, you have any comments?
So Jayanta, we also saw a similar case long back where we thrombolized the patient and the patient started recovering, and while thrombolysis was on, patient developed weakness on other side.
Right.
Not hemiplegic, other side, weakness on other side. And during this process, we were also doing a transthoracic echocardiogram, and we could find a clot in his left ventricle.
Right.
And when this thrombolysis was complete and next echocardiogram, this thrombus was gone. So this was dislodged. So thrombolysis is contraindicated in anyone who is having intracardiac thrombus.
Correct.
But in most of the cases, we don't do echocardiogram before thrombolizing a patient because it is not required unless the patient is having any specific history. So this is the limitation, and
yes,
this can happen. Thrombolysis can dislodge the clot from heart.
Yes, that's a known thing, and that's an unfortunate thing might happen in rare cases, but yes, it does. So I think this is a very good example of that. And is there any question from anybody? Dr. Sanket, anyone, any questions from the chat box or anywhere?
Currently, the chat box is not, I mean, there is no questions in the chat box. So.
Okay.
May
So,
I ask about an experience, your experience on this? Like if the patient has, such an event of rethrombosis, do you directly take up the patient for mechanical thrombectomy, or do you still again like to want to go for CT-angio and spend time there, give another contrast?
I mean, after he deteriorates.
Yes.
After
like we think that it is because of rethrombosis only. Now,
if the patient deteriorates after the thrombolysis, then it has reoccluded, whatever be the mechanism. So I think, and the way he deteriorated, it has to be a large vessel occlusions when the bleed is excluded by a plain CT.
Yes.
So after a plain CT, I think the best way to take the patient to the lab and straight away do a DSA rather than spending more time on the CT angiogram, because you excluded bleed. So it has to be a large vessel occlusions.
So any experience with F6
Well, abciximab is something, it's a double-edged sword. And patients who already got IV TPA, giving abciximab IV on them, first of all, the evidence is very poor. These are all anecdotal, and it is dangerous. I do have some experience of using abciximab in patients who reoccluded after intraarterial TPA. I'm talking about those days where there was no mechanical thrombectomy. So I'm talking about before 2010 or 15, where we used IA-TPA with alteplase, patient reoccluded, then we gave some intraarterial abciximab. But the experience is not very favorable. Some of the patient bled. So patients who is on IV-TPA got some amount of intraarterial TPA and then abciximab is probably not a good idea. So I think you did not give abciximab is probably the right thing you did. And these days, mechanical is probably the only option left for you. But I do not know in this kind of thrombus load what mechanical could have done. But well, it could have been tried by thrombosuction. If it is a soft cardioembolic stroke, then they could have had a chance, but that did not happen. Okay, so all right. So if there is no further question and any other comments from other panelists, then we can move to the next case.
Sure, sir. I would like to invite Dr. Srivardhan, sir, for opening up a slide deck. So you can initiate the screen sharing.
Is the screen visible, sir?
Perfect, sir. We can see you.
So thank you for giving this opportunity. I thank the course moderator, the directors, and the organizers of this. So continuing as the case, unlike Dr. Jasmine's case where there was not a good ending, this case almost has a fairy tale ending. So to start with, our patient was an 83-year-old female, known case of diabetes and hypertension. She was also a case of sick sinus syndrome on a permanent pacemaker for almost last 2 years. And 3 months back, the patient started developing GA bleeding. She was evaluated for the same, and she was diagnosed to have a carcinoma of unknown primary with multiple GA mets. And she continued to have frequent episodes of GA bleed. And she was only on palliative support because they didn't know what the primary source of the malignancy was, and because of her advanced age. And she was initially taking antiplatelets because she had diabetes and hypertension as a MA in stroke prevention. And after this GA bleed, antiplatelets were also stopped. However, her activities of daily living were unaffected and she was able to do all her routine activities. And this was the PET image showing multiple metabolically active lesions in the liver, in the walls of the rectum, and in the walls of the stomach. This patient presented with an episode of sudden fall, followed by paucity of right upper limb and lower limb movements, with a gaze preference to the left side and inability to speak. She had an abnormal breathing pattern. There are no features such of an obvious seizure or incontinence, and no prior history of stroke or TAE. And she was brought to us within 1.5 hours of symptom onset. On examination, her heart rate was 60 per minute because of the pacemaker which was kept fixed, and the BP was 140/70. And patient probably had aspirated. She had a labored breathing with pooling of secretions. There was right hemiparesis, gaze deviation to the left, which could be overcome by Dolce maneuver, and global aphasia with a total score of NHSS of 70. And this was the ECG showing the fact that the pacemaker was working normally. And this was the CT brain. And CT showed multiple lesions on both sides. There are some hypodense lesions over the left insula, over the right parieto-occipital cortices, and in the left coronary data. But clinically, patient had weakness restricted to the right side with the global aphasia. CT angiography was normal. There was no large vessel occlusion as such. So what next to do? We clearly know these are all the exclusion criteria and the fact that gastrointestinal malignancy and any GA hemorrhage in the last 21 days are a contraindication for thrombolysis as per the conventional criteria. But again, the SMART criteria says that none of these are an absolute contraindication except for the fact that the patient has a intracranial bleed. So we discussed with the patient's attenders, the children, the patient's sons and daughters. And after getting an high-risk consent, we proceeded with tenecteplase and we decided to thrombolyze. Thankfully, she had no major bleeding manifestation post-procedure. And within the next few hours, she started showing signs of improvement. The next day, she had 2 episodes of melena, however, they were mild. And she was able to ambulate with support within the next 24 hours. And by day 3, her NHSS was 3. And this is a video of the patient who recovered. This was 2 days after thrombolysis. She was ambulant. So this was a case of a known GA malignancy with active GA bleed, who was thrombolyzed and had a successful recovery. And the patient CT showed bihemispheric infarction, probably embolic in origin, could be cardiac, could be non-cardiac. And the fact that the patient already had a pacemaker ensured that there was not going to be any rhythm abnormality. So probably it was a cancer-associated stroke. And coming to the fact that we use the SMART criteria, which is now being proposed actively, where the only absolute exclusion criteria is an hemorrhage on CT scan, and everything else is a relative contraindication, not an absolute contraindication, and needs to be taken individually, tailoring the patient's need and at the discretion of the treating physicians. So, except for the fact that an evidence for hemorrhage, everything else is supposedly relative. Then we also went and reviewed the literature to find out what exactly the literature says about thrombolysis in patients with GA bleed. And majority of them were anecdotal case reports. However, in 2020, in the European Stroke Journal, I was able to find this particular study, thrombolytic therapy in older acute ischemic stroke patients with gastrointestinal malignancy or recent bleeding. And it was a registry from 1,500 sites, which included 40,396 patients, of which a minuscule amount, just 0.3%, had GA malignancy or recent GA bleeding. So definitely this is being highly underrepresented. And they found that the rates of in-hospital mortality and life-threatening systemic hemorrhage were not significantly different between those with and without GA malignancy or bleeding. If you see the bleeding, the rates were 2.3% in patients with the GA malignancy, and without a GA malignancy, it was 1.2%. But the mortality was grossly normal. But again, the sample size is too small to even extrapolate here. And the third thing which I wanted to bring it to the notice here is the Journal of Stroke, in a recent article where they wanted to reclassify the pathomechanisms for ischemic stroke, they propose a unique entity called a cancer-associated stroke, which can either be cancer coagulopathy related, other cancer causes related, or an incidental cancer. And several mechanisms are being proposed for this cancer-related stroke, including activation of the procoagulant state, the circulating cancer cells, and the other inflammatory cytokines, leading to an inflammatory storm, which can lead to endothelial dysfunction and platelet activation. And the malignancy per se, like an adenocarcinoma, can activate a thrombotic state, something like a Trousseau syndrome. Then hematological malignancy can have a dysproteinemia, a leukoerythroblastic picture, which can again lead to stroke. Then infections in a patient with cancer, which can predispose to stroke. Then therapies, especially the various chemotherapeutic agents, platinum-based, VEGF inhibitors, the small molecule inhibitors, erythropoietin therapy, presence of central venous catheter, radiation exposure. So multiple factors are there which can increase the risk of a stroke. Coming to our patient, because she had a bihemispheric infarction and multiple vascular territories were involved, we wanted to evaluate for a potential embolic event. However, an Holter was going to be not contributory because the patient was already in a pacemaker, and D-dimer was anyways going to be elevated because the patient had an adenocarcinoma. So this led us to a conflict or a doubt what to do for secondary prevention, because literature again says if it's a cancer-associated stroke, the most likely agent to be used would have been an anticoagulant. So we had a doubt whether to give aspirin versus a novel oral anticoagulant, but ultimately we ended up giving just aspirin 75 mg because we are not sure how safe Novak was going to be if there was going to be a GA bleed.
Thank you, Dr. Sivarthan. I think that is another very interesting case. Do you have any post-thrombolysis CT scan of this patient?
No, sir, we don't have any post-thrombolysis CT. And we couldn't do an MRI because of the pacemaker.
Yeah, I understand that. So, well, I think first of all, the stroke mechanism, you did a CT angio.
Yes, sir.
Right. And the CT angio, if you can show us once again, I think the major vessels were open. And,
Yes, sir.
And it was a left hemispheric stroke, right?
Yes, sir. Clinically, right hemiparesis, but she had bihemispheric infarctions.
Yes, but clinically,
Yes,
right,
sir. Left hemispheric stroke.
and it
Clinically,
was
left hemispheric
NIH
stroke.
was 17.
17,
So,
yes, sir.
So quite a bit of deficit. So
Yes, sir. Majorly the power and the language. It was a global aphasia. So
correct. But if we see the CT angio once again, we can see all the way up to the M2s are well visible.
yes, sir.
So the question is, what could be the mechanism in this patient? Because all the MCA and the branches, as far as we could see, are visible. Second is, I think the decision of thrombolysis was absolutely correct, as you rightly pointed, because these contraindications, they are all mostly relative. And cancer per se is not a contraindication unless they are really, really sick with a very limited survival, where your stroke recovery cannot give add a benefit to their life once again, and they have some bleeding complications or something going on at this moment when it is a contraindicated. But otherwise, you can definitely go ahead with any other cancer. So it was definitely a very correct decisions, and obviously that helped the patient significantly. And the third point you raised is the secondary prevention. I mean, all these ESAS trials,
Yes.
where they included the cancer-related thrombosis as one of the possible ESAS mechanism, where we expected that NOACs will be effective in this ESAS group, but they came negative. All this. So as of now, we do not have evidence to give NOACs in ESAS patients, even if they are cancer-related or non-cancer related. So I still put this as an ESAS, maybe cancer-related.
Yes, sir.
But unless we have thrombosis, evidence of thrombosis anywhere else in the body,
Yes.
we cannot technically give NOACs in this patient. But if you look at the subgroup analysis in COMPASS trial,
Yes,
which is a small subgroup of ESAS patients in the COMPASS trial, they looked at the non-ESAS and ESAS patients, and those who received aspirin and rivaroxaban combination therapy of the ESAS group, they actually got benefited in comparison to aspirin alone or rivaroxaban alone. So I think maybe in future, if we do a specific study of ESAS group with combination of aspirin rivaroxaban or aspirin NOAC, that might be more helpful, but that study is not yet done. So we might need some kind of study like this with which is called dual therapy, or antiplatelet, antithrombotic combination, and anticoagulation combination therapy. Dual.
Sir, just want to intervene here, sir. Emcure is doing a study like that, sir. It's called as the in-record study. It is registered with CTRI as well, where we are doing we are recruiting 1,000 patients, and we have two arms. One is the rivaroxaban with aspirin arm, and we have the second arm, which is the DAPT arm, or the aspirin clopidogrel arm. And we have, at this point in time, we have almost 400 patients recruited in that study, sir. And probably we are doing a one-year follow-up. Hopefully, the results would, throw some light on this kind of an aspect.
Is it for the ischemic stroke patients?
No, sir, not for the ischemic, but for the CAD and PAD on the basis of COMPASS study, sir.
CAD and PAD. Okay.
Yes, sir.
All right. Makes sense. All right. So I think Dr. Garg, your comments.
Yeah.
Please.
So Radhakrishnan, I think you were very lucky.
Exactly.
Still, if any patient who comes to me, see, age is no bar, cancer is no bar, but GI bleed, and active GI bleed or recent GI bleed, is whatever literature says, in my opinion, is an absolute contraindication for intravenous thrombolysis. Why? Because recent GI bleed, there is a thrombus formation to stop the bleeding. And thrombolysis is to lyse the thrombus. It's very, very simple. And if somehow bleeding starts, if GI bleed starts during thrombolysis, there is no way to stop that bleeding. Any compressible site, still I'll thrombolize. But non-compressible site, I'll not thrombolize the patient. So IST3 says that to thrombolize whether patient is more than 80 years of age or patient is having diabetic or a stroke or whatever, the patient is on anticoagulant. But GI bleed, in my opinion, because it is a non-compressible site, I'll not thrombolize this patient.
Yes, he was lucky, definitely. No doubt.
Yes, the thing is, more than us, it was the patient's attender who pushed us for the thrombolysis, in spite of explaining everything, because they made the point clear. They felt like if it's a cancer, she's going to live for 6-7 months. She should not be bedridden. You do something, whatever be the outcome, we'll tolerate it.
I would have taken this patient to cath lab and do intra-arterial thrombolysis. Maybe that is a safer choice.
Maybe.
Yeah.
Srivartan, I mean, we appreciate your enthusiasm, but we crossed to that phase. Okay, now we
Exactly, sir. I know.
So I think those who are pushing you to do it, if anything goes wrong, they will pull you down by all possible means.
Yes.
So, I mean, in my opinion, whatever comes, you stick to your principle, your judgment, and don't be, I mean, we get overboard emotionally sometimes. We for the patient, but at times, so I think we should be careful.
Exactly. We felt that we were lucky that thankfully nothing happened, because we never knew the answer what to do if there was a torrential GI bleed.
Braves are always lucky. You are brave, very brave, indeed. Okay, so Dr. Sanket, any questions from the audience?
So currently, I can only see appreciations on the way the thing is getting conducted, the way the cases have been discussed. I think, but nothing in terms of putting into some kind of interaction, some kind of a question that I can see here, sir. So back to you, sir.
Okay. So is there any comments from any of the presenters about any case?
I have a question, a little unrelated to the cases that we have presented. May I please?
Yeah, sure.
Sir, if the patient develops a stroke during the processes like the CABG or when there is cardiac stenting going on, so what is the duration of anticoagulation? Like that is definitely a cardioembolic stroke. So what is the duration of, like, whatever acute thing we have managed, somehow we managed, but what is the duration of anticoagulation after that you prefer to give?
Well, if it is during CABG when they clamp the aorta, or if it is post PTCA when they are catheterizing the patient and catheter is going along the aorta, when they dislodge some plaque from the aorta, that is not typically a cardioembolic stroke. It's still a artery to artery embolism, because those are plaques. So they do not require long-term anticoagulations until it originates from the heart itself by some arrhythmia or some other mechanism. So in that case, we do not have to anticoagulate them in the long run. But if it is due to atrial fibrillation or some valvular heart disease, suppose patient is getting a balloon mitral valvotomy, and this patient develops a stroke, embolic stroke from the heart itself. And if that procedure requires early anticoagulations after a successful thrombectomy or whatever procedure we do, I would rather start early anticoagulations, because if you look at the literature, especially patients with a small to moderate size of embolic stroke, early initiation of anticoagulations within the first 5 days is found to be safe, especially in the NOAC era. if you, there is a nice JAMA paper when they looked at the early oral anticoagulation initiation data in a very large set of population, and they found this is quite safe. So early resumption anticoagulations is not a problem in this kind of patients unless there is a hemorrhagic transformation. Even in case of a relatively large size of infarct, it has also been seen that if they cross 7 days, they are still relatively safe. So this 2-week period is little bit arbitrary. We still follow that, that 1-3-6-12 rule to starting anticoagulations. We follow that from the European guidelines, but that is not a very evidence-based guideline. It's more of an expert opinion. So based on the situation, you can do it early or even late.
But sir, when to stop?
When to stop?
Just like, suppose this is the scenario, like CABG patient developed an embolic stroke, having embolic stroke in bilateral MCA territories or in the bilateral hemisphere. So would you start anticoagulation or not?
No, if it is not a cardioembolic, we
don't have any other evidence, but during CABG, like when the patient came out of CABG, he had that stroke.
If the patient has no arrhythmia or atrial fibrillations, no intracardiac thrombus, then I will not anticoagulate them because they will be recurring antiplatelet, and I'll be happy with antiplatelets. Dr. Garg, your opinion?
See, we see a lot of cases where our center is a major cardiothoracic surgery center where we are doing 15 to 20 cases a day. And we see a lot of post-CABG and post-MVR or after valvular surgery, patients developing in stroke.
Right.
So again, stroke, artery to artery, antiplatelet, anticoagulation is not indicated. If patient has developed atrial fibrillation post-surgery, then definitely anticoagulation is required. And if there is cardioembolic thing, if you are sure that it was because of atrial fibrillation, then continue with anticoagulation for life. That is the strategy. Otherwise, most of the cases where it's white thrombus, that is platelet, artery, then antiplatelet is what is required. Single or double, depending on the size of infarct. I usually start with double antiplatelet in early phases if the size of infarct is small. If it is large, then we start with single antiplatelet. Even in cardioembolic stroke, you may have to hold anticoagulation for some time initial because of risk of hemorrhagic conversion of infarct.
Right. And if it is a post-PCI and patient already got a stent, then probably the cardiologist will like to have 2 antiplatelets. But if it is post-CABG, it's not mandatory to give 2 antiplatelets. We will be happy with aspirin only.
Yes.
Okay. All right. So, Dr. Sanket?
Sir, if you can quickly summarize the meeting, sir, and then I'll initiate with the vote of thanks. Sir.
Okay. So, I think we had 2 very interesting cases. One with a little bit sad ending and one happy ending. But both are very interesting, and we had very lively discussions and 2 different problems and some learning points as well. So both the presenters, they did very well. They prepared the case well and some nice literature review. So I think it was very helpful for the audience to listen to them, and I personally thank them for presenting these 2 very nice cases. And also, I thank my good friend, Dr. Arun Garg, to be here today this evening. And good to see you after a long time.
Yes.
And we'll be meeting very soon in Delhi.
Yeah.
Right.
So all are invited in our conference, World Neurosciences Summit in August 26 to 28, Delhi NCR.
Thank you. We are waiting for that. And Dr. Sanket, thank you once again for giving us this opportunity to be present here and enjoy our time this evening. And No Thrombosis is going to be a very interesting platform of continuous learning in stroke, especially thrombolysis and difficult other stroke treatment situations. Thank you very much, and over to you.
Thank you, sir. Thank you. Sir, I think today's event gave us two ways of looking at it. One is a very fortunate, sir. We have you as our course director. First time that we have you as a course director, sir. And second, Dr. Narinder Rai, who couldn't join us today as our moderator. So, and then we had this unique, so no thrombosis is meant for its unique cases in acute ischemic stroke. And we see on both sides, one where the patient turns out to be extremely well and with an NIHS score of probably closer to 0. And also there are some unfortunate cases like what Dr. Jasmine ma'am has mentioned about where the death is the outcome of that patient. But it's a learning opportunity on both ends, be that the good side or the bad side. So this platform is basically meant for it. And I think as we see the cases, as we see the episodes moving in, we see a lot of learning opportunities for everyone who joins with this meeting. And when I meet them in person, they always come out with some of the take-home points that they have learned or earned from this meeting, from this platform. So as the scientific partner, I would say thank you, sir, for your presence, for the great deliberation, and both the case presenters for the unique cases. I think everyone learned something from the meeting today. So thank you all for sparing your time, and thank you, our course director, sir. Thank you all.
Good night and have a nice weekend. All of you.
You too, sir. Thank you.
Bye.